You address?
I'm making my coffee. You have yours.
All right. I'll just keep admitting people as I see them coming in, but good morning, everyone. Welcome to this Ask the Doctor Zoom discussion with Dr. Jeffrey Margolis. First, please keep your devices on mute unless you want to speak. That way we won't get a lot of interference. I'm Michelle or Mickey McWilliams, and I just wanted to say it was so nice to see some of you at Wine and Dine the D. It really was nice to kind of connect in person after so long. Because this was short notice, I'm sorry, no snacks today, but food's secondary, especially at this hour of the morning. Dr. Margolis is president of Michigan Healthcare Professionals, PC, and professor of oncology at Oakland University William Beaumont School of Medicine. He specializes in treating multiple myeloma, and we are so pleased to have him here today. So I'm just going to hand it over to Dr. Margolis. Please use the chat button to type in a question anytime during the discussion. We'll read all questions that we can, and plus we'll unmute and take questions from the floor. So again, thank you for taking the time for this Zoom. Take it away, Dr. Margolis.
Good morning, everybody. Good morning. Hope everyone's doing well, and congratulations on a very successful Wine and Dine. And hopefully you all got to attend that and had a wonderful panel discussion. So if there's some questions that have come up that you didn't get answered during that panel, I'd be happy to take those, or kind of what's on everyone's mind today. So we have a question list.
We don't have a question list. We don't have anything in the chat yet.
All right, so I need some brave people to go first and ask some questions. Okay, Robert.
Good morning, Dr. Margolis, and again, thank you for doing this. My question is around the booster shot. Now that Pfizer's got one out, can you share any early information on patients who have received the booster and what
Sure.
their responses have been? Thank you.
Yeah. So when you look at vaccinations, vaccinations are not the same among all people. And the American Society of Hematology Leukemia Lymphoma Foundation actually did a study and looked at patients with hematologic malignancies. And what they found is that patients with myeloma, lymphoma, leukemia were much less likely to respond to vaccinations. In addition, patients who have had renal transplants, cardiac transplants, liver transplants, or people who are on immunosuppressive therapy were least likely to respond to vaccinations. So the first group of people that were approved to get a booster vaccine were that group. And what we found is that some of the patients who were unable to mount an antibody response when they were given the first vaccine actually responded and got an antibody response when they got the booster vaccine. In the general population, what we found is that people who have had two vaccines, as they get to be 6 months, 9, 10 months out, their antibody levels start to drop. And when you give them a booster, their antibody level, starts to go up. So there's some controversy about whether people who are not immunocompromised truly, need a booster, and if that waning antibody is going to cause a problem for them. For people who are immunocompromised or on chemotherapy or on treatment, I don't think there's any controversy for that group of people. People need to absolutely get boosters because the first two vaccines are not, adequate for them. Perfect. So when we look at antibody testing, a lot of people poo-poo antibody testing, and there's some truth to that. I can't tell you what a therapeutic antibody level is. So no one knows if your level is 10, 100, 200, what's, good enough. But I think what everyone can agree is if you get an antibody test and it has no antibodies, then you're probably not adequately vaccinated. And what we've seen in the hospital right now is that the vast majority of the patients who are in the hospital or sick enough with COVID are people that are either unvaccinated, or there are people who have been vaccinated, and a lot of those patients, at least of mine, were vaccinated that I knew didn't have an antibody response, who had another comorbidity or a reason to think they weren't going to respond to the vaccine. So, one of the things that we can do as a group of people on this call is really advocate that, all of us end up getting boosters, but more importantly, is advocate for these people who are unvaccinated to get vaccinated. And the best way to get rid of this disease is to get everyone around us vaccinated. And this whole idea that people talked about at the beginning of herd immunity is absolutely correct. If everyone else is vaccinated, if you don't respond to the vaccine, it doesn't matter because there's not going to be any COVID around. And maybe some of us on this call are old enough to have been vaccinated against smallpox, but the truth is I've never been vaccinated against smallpox, and I never worry about getting smallpox because it's been eliminated. And you can eliminate diseases by vaccinating the rest of the population. And then the people who don't respond to the vaccine or don't do it, there's just not enough of the disease around to cause people to get sick.
Dr. Margolis, for people here that have been vaccinated and they're worried that they don't have enough immunity to the virus, should they talk to their doctor about getting the test to test their antibodies?
Yeah, so I think if you are a support person or a spouse or a friend of someone with myeloma, doing antibody testing for the routine population, I'm not sure that's that helpful. I think for people who have myeloma, doing antibody testing is absolutely helpful. Now, sometimes when you do antibody testing and the antibody comes back negative, it's worse than telling people that they have myeloma, because then people feel like, they're not protected, they're stuck back in their house and bad things happen. So I always have a discussion, with people and say, do you really want to know that answer? Because some people, are absolutely crushed by that knowledge. The other thing, though, that I think is really, really important for this group to understand is that there are two companies that make monoclonal antibodies against COVID. And monoclonal antibodies are pre-made antibodies. If your body can't make an antibody, then they can make them in a bottle against COVID. And when President Trump got sick, he got the Regeneron product. Well, that product and an Eli Lilly product are now both approved for the treatment and prevention of COVID. So if someone who has high risk of progression, even if you're vaccinated, were to get COVID, so your nose feels runny, you lose your sense of smell, and then you go ahead and get a COVID test, it's really important that you contact your doctor, because at that point, you actually could get treated to prevent yourself from going on to get sick with one of these monoclonal antibodies. And it's a quick outpatient infusion, and it works amazingly, amazingly well. It reduces hospitalizations by almost 50%. The drugs are so good that most people don't realize they actually have an FDA approval now for prevention. So let's say you went to a dinner party, everything was a great time, and it turns out the person next to you the next day had COVID. Well, if you get exposed to someone with COVID and it's an honest to goodness exposure, you can actually get these antibodies as a prevention from getting COVID. But again, it's really, really important to know this information and to contact your doctors. A lot of the physicians, especially the primary care doctors that are out there, they don't know that the drug's been approved for prevention. And a lot of them don't know that you can still use it in people who are vaccinated. Other questions?
So this is a really good time for all of you, anyone that has some questions about anything as it relates to multiple myeloma. It doesn't have to just be about COVID and vaccinations. It can be about your, whatever is on your mind. So you can put it in the chat, or you can just unmute and speak up. We've got a small enough group right now that that wouldn't be a difficult thing to do.
Dr. Margolis,
Yes.
my husband had CAR T in September of last year and has been doing wonderfully. I'm the person who's looking forward and saying, okay, so we know this won't last forever. What's the next line of treatment that's being used when CAR T fails?
So I don't think we have a standard line of treatment yet after CAR T. And, depending on where he was transplanted, if he's had a transplant, whether he's been on, medications in the past. So a lot of times when we look at myeloma and we're trying to pick treatment, what we look at is what were you treated with in the past? What did you respond to in the past? How long were your responses to what you've gotten? And then we add those, that we can mix and match all those drugs. So we've got now probably 10 or 12 different drugs that we can use to treat myeloma. And then those drugs can all be used kind of in combination. And if you've had CAR T, it doesn't exclude you from using any of those combinations. So what we would do is we would go ahead and do a history of that and find out what drugs you've used. In addition, at the time of relapse, I encourage people to participate in the cloud study that the MMR is doing. And that's a test where they do blood work on you at the time of your relapse. And what they'll do is a complete genetic profile of your myeloma. And based on that genetic profile, sometimes that will help us make a choice on which treatment to use. So what we try to do is tailor the treatment based on drugs you've been on before, responses you've had before, on genetics. And then the last thing that helps us pick the treatments that you get is what side effects have you had or have had problems with. So for example, if your myeloma has caused a lot of neuropathy, then we probably would try to avoid drugs that cause neuropathy. If you've got problems with your heart, then we would try to avoid some drugs that can be associated with heart problems. So we kind of globally pick their thing, and that's why there's not one good standard answer on how to treat people with relapsed myeloma.
There's a question in the chat. What causes a non-response to the vaccine, the treatment or the blood cancer?
Both. So when people have myeloma, one of the things that we all know is that we have a plasma cell. And the plasma cell are the cells that make antibody. And so that antibody that's being made is that spike or that free light chain that you're following in your blood. But what most people don't pay attention to is that when you have myeloma, if you look, your normal antibodies are actually suppressed. So if you have an IgG myeloma, it's very common for your IgM and your IgA to be lower. In addition, your normal IgGs are often lower. So if you do something called IgG subsets, the amount of other IgG, not the myeloma IgG, is low. And that's because the myeloma itself causes immune dysregulation and it suppresses out the normal cells that make antibodies. And then on top of that, when we're treating myeloma, we're giving you medications that suppress the immune system. So, one of the things that dexamethasone does is it kills plasma cells and kills myeloma cells. Well, it also then kills normal plasma cells and normal lymphocytes, which are what are there to make the antibody. A variety of the treatments that we have also kill lymphocytes and T cells, so they suppress the immune system. And so, unfortunately, patients with myeloma are at higher risk for getting infections to begin with. So it's not a big surprise that their response to the antibody, their response to COVID tends to be worse because they can't fight off the COVID. And it's also not a surprise that people with myeloma don't respond to the vaccine as well.
Anybody else have a question? This is a really good time to speak up. We've got time.
Yeah,
Hey
go ahead.
there. Hi, I'm on that webinar. What? The webinar.
I
Oh.
muted it. Anybody else? There's, we've got some time here, and I know that you all have questions, and it can be about your personal experience, anything that you want to ask. So please take the time to, speak up.
I was wondering, what is the name again of the study to participate in if you relapse?
Sure.
I missed that.
So if you go to the MMR website, it's their cloud study, and it's a cool study because you don't need a doctor to register for the study. The way you do it is you go on the MMR website, it's patient driven, and you actually register for the study yourself. You take the piece of the study and you say to your doctor, hey, I want to be on this study. They sign off a form, and the MMR actually will send a phlebotomist to your house to draw your blood.
Okay.
And then they'll send you a copy of the blueprint, and they send your doctor a copy of the blueprint of the things that they found.
Okay, great. Thanks.
Is that
You're welcome.
the first,
What?
is that the first relapse or like after the CAR T?
You can do it at first relapse. You can do it at any time when you have myeloma. Some people do it right at, diagnosis now.
Oh,
Okay,
that's interesting.
yeah.
So we have another question in the chat. What is the current average time CAR T is lasting? Any new research on that?
So CAR T, when it first was being used on the original studies, showed a very high response rate, but the patients who were getting CAR T were all people who were super, super, super refractory. If I listed those 10 meds, they failed those 10 meds plus any kind of combination. And the responses for that were typically short-lived. Most of the patients relapse within a year. What we're seeing now is that CAR T is being used earlier in treatment with less refractory patients, and we're starting to see, better results. The biggest problem with CAR T is that it's hard to get the drug. So it's so good and so powerful of a therapy that the manufacturer of the drug's having enough time keeping up with the supply of the drug. So most centers don't have a lot of CAR T therapy, and there's a long waiting list for it. In addition, CAR T is a type of treatment, and that type of treatment is to take a T cell in your body, basically they take it out of your body, they genetically engineer it and make it a super soldier, and then they infuse it back into your body to kill myeloma. Well, the first round of CAR T is to a target called BCMA. Well, the truth is that's the first round of super soldiers. They're now working on CAR Ts that have other targets besides BCMA. So eventually you may find that with CAR T, you won't just get one super soldier, you'll get an army of super soldiers that are all, different targets. So I think this continues to evolve. And so we're still, even though there's commercially available CAR T, we are also still doing studies with CAR T. And those studies are open, around us, both at Michigan and at Carmanos to use CAR T, which is the commercial product, which is ide-cel, as well as multiple experimental products.
Oh. Any other questions?
I see some stuff coming in the question log. Michelle, I can't see them once they flash up. If you can read them to me.
Yeah. Oh yeah, here, I do have more. Have you ever heard of ivermectin to treat COVID?
Yeah, so ivermectin is one of these things that appeared on Facebook and in the rumor mill. Ivermectin is a drug that's used as an anti-parasite. It's a deworming medicine. There is very, very, very little data that ivermectin does anything for COVID. It's it's in the same thing that Plaquenil would help for COVID. And if you remember early on, everyone was screaming that you had to have hydroxychloroquine. People had to run on the market, to do things. And it turns out it didn't do anything. The really bad thing about ivermectin is that there are treatments for COVID, and there are treatments that absolutely work. These monoclonal antibodies that we have for COVID are fabulous, and they work. They keep people out of the hospital, and they make it so people, do much better. The downside with the monoclonal antibodies is that once you're sick, then and you're requiring oxygen, the monoclonal antibodies don't work. And part of what happens in COVID is that once the disease gets going, it triggers a terrible immune response, and you get what's called a cytokine response. And then the disease is not just driven by the virus itself, it's driven by your body's response. And when that happens, you actually cannot treat it with the monoclonal antibodies. So if people start doing things like ivermectin, waste their window to get treated with the monoclonal antibody, and then show up really sick, then our options are much more limited. Merck's going to have an oral drug that's probably going to be available to treat COVID that looks like it decreased hospitalization rates by 50%. That will be kind of the Tamiflu equivalent of for flu, that I think is going to be a big blockbuster drug. And that's why I would stick with drugs that are gone through rigorous testing, that are FDA approved, that we know that work, rather than stuff that got started kind of on a rumor mill.
Right. And ivermectin is, it's what's in the pill that I give my dog for heartworm. So
yeah.
I have a couple other questions here. What is the life rate of a port?
So I've had ports go for 5-10 years. And then I've had some people whose ports get infected or have problems, very quickly. Most of the time, if you take care of the port and you flush it and you do the things that you're supposed to do, they go for years and years. With that being said, I've had patients who had a port put in, and then because of COVID, haven't come out of their house for 2 years, showed up in the office, the port wasn't maintained at all, and they still work fine. So, most of the time, the Metaports last a very long time. Usually when people get into trouble with the ports, they get into trouble early on, and they get infected or clotted or something early on. But once they've been in for a while, they tend to stay for a long time.
Another question here. I participated in a 2-year study, 2019 to 2020, May timeframe. Had not done EKG during COVID period, just got an EKG and see some anomalies. Is it likely from the long-term treatment with Revlimid?
Probably not. People get lots of non-specific EKG abnormalities. And people, when we're doing studies on drugs, when we don't know what the drugs are going to do, we do a whole bunch of tests that are probably, meaningless, just to look for side effects. And one of the things with, Revlimid is that in natural practice, if you're not on a study, no one would get an EKG on you all the time for it. So over time, EKGs change. I doubt it has anything to do with the Revlimid. And most of the non-specific EKG changes that you see, there's nothing you need to do anything about. There's 2 EKG changes that we are usually concerned about. One is if your EKG shows signs of ischemia, so your heart's not getting enough blood, and you see that when someone's having a heart attack or they're having angina. And most time you would know that. You probably wouldn't see that. And then some drugs cause what's called a QT prolongation. And that's an electrical abnormality in the heart. And when the QT gets longer and longer, it predisposes people for getting some arrhythmias. And the arrhythmia that people get is something called torsade de pointe. I've done and treat lots and lots and lots and lots and lots and lots of patients over 20 years. And in the 20 years I've been treating lots and lots of patients and doing the EKGs, there's only 1 or 2 patients who've ever had torsades de pointe. So even when you see that QT interval get longer, most of the time there's not anything you need to do. If it gets super, super long, then sometimes you have to stop the medicine.
Another question is if you were treated with CAR T protocol, is it possible that a lesion pain would dissipate or disappear?
Yeah. So when people have myeloma and they have pain for 2 reasons. The bone lesion that they're getting is being destroyed by the cancer, and the bone is actually being destroyed by itself. So we can use to take that bone lesion. It's actually very easy to kill that bone lesion that's causing pain. CAR T can do it, Revlimid can do it, radiation can do it, all kinds of things do it. And often the pain will get better because the lesion that's there dies, the lesion shrinks, it stops pushing on the nerves and stops causing the pain. On the other hand, as the bone destroys as the myeloma destroys the bone, you can get arthritis, or the joint won't function as well as it normally did because it was actually, damaged by the myeloma, and you can have pain that has nothing to do with the myeloma. The myeloma could be gone, but the joint itself may not be normal.
Anybody else want to unmute and ask a question or throw something in the chat?
Yeah, I'll ask something. I put something in the chat. I'm curious about just overall survival rates. I know it's good news that with so many positive medications, survival rates are getting better and better and better, and they have been doing that for a while. Is there some overview perhaps you could share, like the overall 5-year survival rate or 10-year or something to that effect?
Yeah, I'm reticent to put numbers on things because numbers are really meaningless. And so when you pick a number, and I'll take a myeloma thing in a period of time, that period of time changes so fast. So in the era when there was melphalan and prednisone, that was the only treatment for myeloma, people lived about 2 years. But because once you relapse, there was nothing that you can do. Well, every time that you give a new drug, you have to reset that survival curve and things because you can keep rescuing people. So for myeloma, I no longer think about it as an acute disease where you get myeloma and you pass away or you got pain. You treat it as a chronic disease. And usually what you do is you get treated, you go for a period of time, and then the disease will relapse or misbehave. Then you pick another drug and you treat it, and you go for another period of time, and then it misbehaves and you keep doing it. Well, we keep adding drugs every year. So that survival curve for myeloma keeps getting stretched out and stretched out and stretched out because we're not running out of drugs the way we used to. And, even when Revlimid came out, you had, Velcade and Revlimid, and then you had nothing. Well, now we've got so many things. And then the other thing that happens is that you can recycle the drugs. So, we've got lots of myeloma patients that are now out 5, 7, 8 years, and some of the drugs they've been on, they haven't been on in 5 or 6 years. You can actually go back to the beginning and start to use some of those drugs to bring them on. So I think this is truly a real moving target. And as we continue to make progress in myeloma, we're going to continue to see that survival curve, go out. So if you pull a survival curve and it says the 5-year survival was X, well, that by definition had to be 5 years ago. Well, no one treats myeloma the same way that they did 5 years ago as they do today. So, since we've been doing wine and dine and we've been doing these calls, there are multiple new drugs that have been approved. I think every single year we've done something, we've had new treatments and new options come up.
Thank you.
Sorry, Steve, I did see that in the chat, and then I skipped it, so I missed it. Sorry. So, anyone else? Please feel free to unmute and talk a little bit. We'd love to hear from you. Did any of you have questions that didn't get answered from the wine and dine and the D? I know that there were questions in the chat there that that we weren't able to get to. So I don't know those questions because I wasn't the one recording it or looking at them. But does anyone here have a question that they asked that they didn't get answered at wine and dine and the D? No, everybody's happy? Or is it just a little too early?
I have a question. How are you following non-secretor patients? Is there anything other than bone marrow available?
One more time.
How are you following patients with myeloma who are non-secretors other than doing repeated bone marrows?
Yeah, what I try to, so a lot of the people that used to be called non-secretors in the past often will still have a small amount of free light chain that's around. And so I look for a marker, free light chain, if I can follow it. And then the easiest thing to do is to actually follow them with PET scan. And PET scan can pick up disease in the marrow, and it can pick up early new bone lesions. Just because it's so invasive and it hurts, I try not to follow people who are non-secretors with bone marrows. If I see on the PET scan new lytic bone lesions, I'll do a bone marrow. If I will see new cytopenias, so you follow the blood counts, and when you come into the office, you're always getting a white blood cell count, hemoglobin, and a platelet count. If all of those were going to start to change, or one of them would be changing, that would be a sign that something's going on. But usually, just to do periodic bone marrows on people isn't that helpful.
A couple questions in the chat now. Any new research on what causes multiple myeloma?
Yeah, so people have been trying to figure this out, forever, and we don't have a real good answer. We know that as people get older, there's more myeloma. There has been, some links to ionizing, radiation. There are certainly some pockets of the country, Michigan having more myeloma than some other places. So there's probably some more environmental factors that are there, but not an absolutely really good cause at this point.
Okay, another question. Speaking of wine and dine, does alcohol have a negative effect on multiple myeloma?
So, most things, if you do it in moderation, is fine. And I tell everyone, if you have a shot of whiskey, nothing bad happens to you. If you drink a bottle of whiskey, you've got a big problem. And like everything else, I think if you're occasionally indulging in some alcohol, you're probably okay. If it's something that's a habit and you're doing a large amount of alcohol at any given time, then I think there's potentially problems for it. And that holds true for people with myeloma, without myeloma, and with cancer as well. So I've never seen anyone with myeloma who had a glass of wine at the Wine and D have anything bad. I think Sid and I are going to be doing a study of that next year. But what I do see is that it reduces stress, and it certainly doesn't do anything bad if you have one or two glasses. I think you need to be careful in that alcohol, when you mix it with some of the drugs that people with myeloma take, can cause some problems. And so if you happen to be taking narcotics because you're in pain, if you're taking Ativan or Xanax because you're having a lot of anxiety, the alcohol tends to interact with those drugs and intensifies it. And so you have to be very careful, because if you do that, you may have taken only one narco and it will feel like you've taken three.
Great. Other questions? One thing, Barry, you sent me an email asking about the Wine and Dine the D recording, and I don't have that yet, but I'm hoping I'll be able to get that from the the company that did the recording in a day or so, I hope, and be able to put that up on our website. And I will send an email out and let everyone know when that recording's up so you can watch it if you weren't able to go to Wine and Dine in the D, or if you just want to rewatch it. So it will be there as soon as I get it.
Thank you.
Actually, I did want to ask a follow-up about the alcohol question because I just saw my transplant specialist and I asked about that. I'd asked Dr. Zonder too, who's my oncologist. And my question is, what's the definition of occasionally? Because I asked my transplant specialist, is it okay to have a glass of wine at dinner once a week, once every 2 weeks, once a month? And, you know, I noticed you use the word occasionally, and each doctor related to my multiple myeloma I asked this said the same. But what is occasionally?
So you've caught your doctors all in a big hedge, because I don't think anyone knows the answer to that. Certainly a glass of wine once a week, I would be more than comfortable with that. If it's, every day, yeah, it's probably okay if it's a small amount. If it's, starting to be more than that, then no. And that's what I would tell people that don't have myeloma. Alcohol should be something that you drink, in moderation, and probably no more than a glass a day. And I would encourage people who have other illnesses and stuff to probably be, less than that. And what it doesn't mean is that if we said you could have a glass of wine, a day like they do in a lot of European countries, it doesn't mean you get to save it up and then have 6 on a Saturday. It really is the quantity that you drink at one time more often than the actual frequency.
Thank you for clarifying that.
You're welcome. I'm glad we're all consistent with occasionally.
Well, anything else anybody wants to bring up? We have a few more minutes, not a whole lot of time, but we do have a few more minutes before Dr. Margolis has to go. So if anyone has another question, this is a really good time to bring it up. Okay. I don't see any other questions in here. Dr. Margolis, is there anything that you wanted to say to people right now, related to multiple myeloma or to, to our pandemic? Anything that you want to say that we haven't talked about yet?
Yeah, so again, I hope this pandemic's coming to an end. I think, again, it's important that you continue to be able to communicate with your doctors. Make sure that you have access to your doctors. So it's not just the time that you have, during your visit, but know that if you have, you're sick, that you have an action plan to do it. So if you have a big exposure, you get sick, that you know how to, contact your doctor so your doctor can take, some kind of, action. I think as a group, so we can be proactive about things. I think, again, making sure that everyone has gotten their booster vaccine is important. We should be, as a group, we should be big advocates of people around us getting vaccines. And even if people don't want to do it for themselves, they need to be doing it for other people. And you can stress you're in a unique position to tell people that they need to do things to help you so we can all help ourselves. But I really do get the sense, in looking at the numbers, I'm very optimistic that this is starting to come down. We're seeing, hospitalization rates go down, death rates go down. People are slowly starting to get, vaccinated, and the whole, rest of the country will kind of move. And eventually, you're going to get vaccinated one way or another. You're going to either get vaccinated or you're going to get COVID. And eventually you're going to get, some kind of natural immunity to this as well.
So I do have another question that I have heard people ask before, and that is, if you got the Moderna shot and you aren't eligible, therefore not eligible yet for a booster, should you get the Pfizer booster?
Yeah. So what's confusing everyone and what makes people feel like some people aren't being straightforward with them is there's a difference between the science, the policy, and how things, roll out. So as data comes in, we start to generate science and data. So that's what physicians sometimes will talk to people about. And then that data goes into regulatory agencies, and the regulatory agencies then start to make decisions about what they want to do with it. And if you look at the booster, that's a great example of what this happened. Their data started coming out on the booster. Then the booster data started coming out, and then the FDA made a decision on it. And then that same data, the CDC made a different decision about the policy. What I can tell you as a doctor, I don't have to rely on what's good for the whole population. I don't have to rely on what's good for the whole world. And so there are people right now at the World Health Organization that thinks giving boosters are immoral because the rest of the world isn't vaccinated. All I can say is I can only do what's right for the person who's in front of me. And what the science clearly shows is boosters work. And it also shows, and there was a study done by the National Institute of Health, that mixing vaccines doesn't hurt you and you can get immune responses. So if you got a Pfizer and you got a Moderna booster, it's fine. If you've gotten, Moderna and you want to get a Pfizer booster, that's fine. And the truth is that most of the drugstores, if you go in and ask for a booster, they don't care whether you had a Moderna or a Pfizer. I would just grab a booster. I think it's very reasonable if you've had 2 Moderna to go ahead and get a Pfizer booster. The Moderna vaccine is a little bit stronger than the Pfizer vaccine. And when Moderna finally comes out with its booster, it may actually be a half dose of the vaccine rather than a full dose for the booster. What people also have noticed is that when you mix and match, you may actually get a stronger antibody response. So it's more like a natural infection, and it stimulates the immune system more because it's doing it in 2 different ways. So what I think I can tell you is that it's absolutely safe to mix and match. And when you do mix and match, you absolutely do get good antibody responses. And so what I always tell everyone in the office now is get a booster when available, which means if you can find someone to give it to you, go ahead and take it. And it doesn't matter which kind.
Thank you, because that is something that that many people have asked, and I certainly don't know the answer to that, but that makes a lot of sense.
Yeah.
Well, Dr. Margolis, it is 8 o'clock, and I know that you, Stacy told me you've got patients that and can only stay until now. So I really think that it's time to wind this up so you can go see your patients. But I want to say thank you very much for taking the time to do this. And thank you, all of you on this call, for getting up early and being here joining us so that everyone can learn from this discussion. So with that, if there's anybody else that wants to say one other little bit of a thing, we can, or we can just sign off now.
Thank you very much.
Thank you for your time.
Oh, thank you, everybody, for coming out so early, and be safe.
Yep.
Thank you.
Take care, everyone.
Take care.